Thanks for the opportunity to join you today. I'm Matt Milowsky. I'm a professor of medicine at the University of North Carolina at Chapel Hill and the section chief of genitourinary oncology. And I'm going to speak today. The title of my presentation is Clinical Investigator Perspectives on the Most Relevant New Data Sets and Advances in Oncology. And this is the bladder cancer edition, for which there's been a tremendous amount of promise and excitement. I'll start with some abstracts looking at non-muscle invasive bladder cancer. This has historically been more of a urologist's disease, but medical oncologists are getting more involved. And so this is an abstract that was presented by Andrea Necchi at the GU Cancer Symposium, and looking at pembrolizumab for BCG unresponsive high-risk NMIBC. And so previously, the cohort A results were presented from the Keynote 57 study. And so again, this is looking at patients with high risk non-muscle invasive disease with CIS, and they could also have papillary disease. And this was the initial presentation of cohort A. Here are just some background information about the criteria for the definition of adequate BCG and BCG unresponsive disease. These are criteria that are endorsed by the FDA and used in the context of the trials that are looking in this clinical space. And I think, probably the most important thing without getting into the details is just to point out that there's different types of BCG unresponsive disease. There's those that progress. There's the persistent high-risk non-muscle invasive disease, and then the recurrent disease in spite of adequate BCG. And so the original data from cohort A was presented and subsequently published by Arjun Balar in Lancet Oncology. And this looked at cohort A, which was results from CIS plus or minus papillary tumors. And this showed a clinical complete response rate of 40% at 3 months, which was, deemed to be very promising. There was some disappointment in seeing that these CR rates weren't maintained in all patients. It was about a little under 20% ultimately that remained in CR. However, certainly a novel approach with a checkpoint inhibitor in this particular clinical disease state. And so this is the data from cohort B. So this is patients with papillary tumors only without evidence of carcinoma in situ. And so this is the schema for the trial design. And again, these high-risk non-muscle invasive patients, we're talking about cohort B now. So these papillary tumors without CIS receiving pembrolizumab for up to 2 years. They undergo a series of different assessments with cystoscopies and urine cytology and imaging studies. And then, of course, if they develop recurrence or progression, they discontinue or continue treatment in the event that there's no evidence of recurrence or progression of disease. This is the characteristics of the patients in the study. So again, these are the high-grade T1, TA patients, and you can see that they're binned into the persistent, recurrent, or progressive groups. So most of these patients had recurrent non-muscle invasive disease. And so here's the data. Here's the Kaplan-Meier curve for disease-free survival. So here you can see that the 12-month DFS for this patient population was about 44%. You could see this falls off at 24 and 36 months at about 35% with a median disease-free survival of 7.7 months. If you look at the treatment-related adverse events, I think, consistent with what we all know in terms of the use of immune checkpoint inhibitors. So you see your typical pruritus, diarrhea, asthenia, rash. You have your thyroid dysfunction, and then the less common side effects. Here, grade 3, 4, in about 14% of patients, and about 10% discontinued therapy. And so, what does this all mean? I think it means that pembrolizumab continues to demonstrate anti-tumor activity, not only in that CIS cohort, but also in the T1 TA high-grade cohort. The safety profile is consistent with what we see for immune checkpoint inhibitors. And I think it represents a strategy for patients with high-grade T1 TA BCG unresponsive disease. There's a lot coming down the pike in this particular area, so this is hopefully going to be one of many types of approaches. There's been some interesting data looking at combination type approaches. This is a really nice study that was published by Noah Hahn. This actually came out of an NCI clinical trials planning meeting years ago. And this is being coordinated through, or was coordinated through, the Hoosier Cancer Research Network. It's called the GU16243 ADAPT Bladder Study. So it's a trial of durvalumab, the anti-PD-L1 agent, with BCG or external beam radiation therapy, again in that BCG unresponsive NMIBC population. So this is, again, small numbers of patients here, but it was really looking at a multi-arm, multi-stage type trial design to look at durva in combination with other agents that are active. And so here with BCG in cohort 2 and in cohort 3, it was external beam radiation therapy. And so what we see here is that you get durva for up to 8 cycles, and then you get standard sort of intravesical BCG. And in the external beam radiation therapy cohort, it was 6 gray times 3 in cycle 1, and then evaluated with a 6-month required biopsy. From a toxicity standpoint, about 30% of patients across all cohorts experienced grade 3, 4, 14% with dose delays due to toxicity, and 14% discontinued durva due to toxicity. And again, I think this is once again consistent with what we see, with immune checkpoint blockade. Here, if you look at the CRs, this is particularly interesting in the durva plus BCG cohort with a 12-month CR rate of 73%. Again, small numbers of patients, but certainly a suggestion that there's activity here in CRs in nearly 2/3 of patients across the combination cohorts. And so, feasible, safe in BCG unresponsive NMIBC. I think there's encouraging preliminary activity here. But I think really most notably, this novel multi-arm, multi-stage type trial design really facilitates rapid evaluation of novel therapies, here being combined with anti-PD-L1 or, other immune checkpoint inhibitors. And I think there's justification here for using these combination approaches. And there's a bunch of studies going on looking at these combination approaches, particularly with, as an example, BCG in combination with immune checkpoint inhibition. Staying in the theme of non-muscle invasive bladder cancer, these are some data, again, from the Genitourinary Cancer Symposium. This is the THOR-2 study. This has, you can see 3 different cohorts of patients. This is the cohort 2 interim analysis. So these, again, are small numbers of patients. Here, these are patients that are molecularly selected for having FGFR alterations. And we bin them into a high-risk non-muscle invasive papillary only, no CIS. Cohort 2's much what I described earlier, the CIS with or without papillary disease, and there's an intermediate risk cohort, which I'll speak to. And these patients are treated with urothelial, which is an FGFR 1 through 4 inhibitor, which is approved in patients with advanced disease. And the exploratory endpoints were CR rate at cycle 3, day 1, and cycle 6, day 1, so 3 months and 6 months, and secondary endpoints, including toxicity. And so you could see the CR rate at 3 months, 100%, and at 6 months it was about 75%. The median duration of response was approximately 3 months. And so, certainly evidence that there's activity here in non-muscle invasive disease, where we know that there's a higher prevalence of FGFR alterations as compared to muscle invasive or metastatic disease.
What do we know about mechanisms of resistance to BCG, and what's the rationale, getting back to the previous study you were talking about with durvalumab, of combining an IO with BCG in a patient who's resistant to it?
Yeah. So I think that, it's an excellent question. I think the mechanism of BCG is still not entirely clear. It is the first sort of immunotherapy agent in a lot of ways, and we often forget that, stimulating an anti-tumor response. However, the specific exact mechanism, less is really known. And, I think the idea of sort of augmenting the immune response systemically while giving intravesical BCG for a local immune response is certainly the hypothesis here. And the rationale behind doing these type of combination approaches with BCG, even in those unresponsive patients. So again, erdafitinib activity in non-muscle invasive disease in this cohort. If you look at the toxicity profile, here you can see there are the typical erdafitinib-related adverse events. You could see treatment-related grade greater than or equal to 3, treatment-emergent adverse events about 30%. And if you look at the exact events, they're what we see with erdafitinib. I mean, it's not an easy drug to give. You have to be familiar with the side effects, the dry mouth, diarrhea, hyperphosphatemia, dyschezia, stomatitis, the nail disorders. And so, my conclusion here is that efficacy is observed with erda. It looks like in small numbers of patients. The toxicity profile is consistent with the known side effect profile of erdafitinib. And I think, as we look at these agents in earlier stages of disease, whether it be immune checkpoint inhibition or FGFR inhibition or others, we have to think about that risk benefit profile in non muscle invasive disease as compared with more advanced disease, acknowledging the fact also that these patients with refractory disease will go on to lose their bladder. So it's not inconsequential. Cohort 3, this was an interim analysis, a very different cohort. This is intermediate risk non-muscle invasive bladder cancer. So these are the tumors that have a high recurrence probability, greater than 50%, but a much lower progression probability. And so these are all prior tumors that had to be low grade, grade 1, 2, TAT1, no prior carcinoma in situ. And here you can see, again, erdafitinib treatment, and here looking at the CR rate, about 75%, median duration of response about 2.8 or so months. And the toxicity profile, once again, is very consistent with the erdafitinib-related side effects. What I would say here is that I think as we go earlier, we definitely need to be more and more thoughtful about the sort of toxicities that we're seeing in our patients, particularly for some of these diseases which represent more of the nuisance type of disease with continued recurrences as compared to those that progress to a more lethal phenotype. Moving on to muscle invasive bladder cancer, this is an exciting agent that has demonstrated activity in non-muscle invasive disease. This is a really nice publication by Sia Danishmad in Urologic Oncology that looked at this agent called TAR-200. We call it the pretzel based on the way it appears. It is essentially a delivery device for whatever you want to deliver. In this case, the TAR-200 is gemcitabine, and it's administered in two 7-day cycles. In this particular trial, it looked at patients with muscle invasive disease who were either not candidates or declined cisplatin-based neoadjuvant chemotherapy, and they were binned into arm 1 or arm 2 with larger or smaller tumors. Safety profile looked quite good. These are the treatment emergent AEs that were classified as TAR-200 related, so only 17%, and these were procedure related. And there are really no major toxicities associated with this, really grade 1, 2 type events. Looking at preliminary anti-tumor activity here, pathologic responses in 40% of patients. These are less than PT2. And then here you can see that these were about 60% in this arm with smaller tumors, that is less than 3 cms. And so, I think this is certainly interesting preliminary activity for an intravesical drug delivery system, and hopefully holds some promise for the potential use of intravesical therapy in the context of muscle invasive disease. So, we know that a lot of treatments in muscle invasive disease are underutilized, or we can't use them for one reason. TAR-200, novel intravesical gemcitabine delivery system, seems to be well tolerated, safe in patients with MIBC. And neoadjuvant TAR-200 demonstrated what looks to be some anti-tumor activity in this phase 1 study. So I think more to come. And here is what is to come. This is some trials in progress posters that were presented at the GU Cancer Symposium. This is by Dr. Sutka. This is the Sunrise 4 study looking at TAR-200 plus citrilimab, which is an anti-PD-1 agent, or citrilimab alone as neoadjuvant therapy in patients with MIBC who are ineligible or refuse neoadjuvant cisplatin-based chemotherapy. So, fairly straightforward trial design with a primary endpoint of pathologic complete response at the time of radical cystectomy. There's also some other agents. As I mentioned, this is a delivery device system, and so you can deliver different agents. In this case, it's delivering erdafitinib. This is a phase 1 first-in-human study. So these are, again, molecularly selected patients with FGFR alterations, and they, again, are being looked at in the context of different cohorts. There's a high-risk papillary-only cohort with prior BCG, refusing cystectomy, a papillary-only NMIBC, prior BCG planned radical cystectomy, an intermediate risk, and then the muscle invasive. and receiving this again intravesical delivery system with erdafitinib, again in molecularly selected patients. And so I think quite a bit of excitement with these novel delivery systems to be able to now um, send agents directly into the bladder with potential activity. Moving on, again, muscle invasive disease. This is some very nice data that Dr. Galsky updated at the Genitourinary Cancer Symposium. This is extended follow-up results from the Checkmate 274 trial. This was a randomized double-blind multicenter study of adjuvant nivolumab versus placebo in high-risk MI UC. And so these are patients with high-risk disease, so they could either receive neoadjuvant cisplatin-based combination chemotherapy and had persistent muscle-invasive disease, YPT2, or if they didn't receive neoadjuvant therapy, they had PT3 and/or node-positive disease. Here, randomized to nivolumab versus placebo with a primary endpoint of DFS in the all randomized ITT population and the PD-L1 greater than or equal to 1%. And so the original data was published in the New England Journal of Medicine. This had a median follow-up of about 21 months, and adjuvant Nivo improved the DFS versus placebo in the ITT. The hazard ratio was 0.70, and in patients with PD-L1 expression greater than or equal to 1%, it was 0.55. And so this presents the extended follow-up with a median follow-up of about 36 months. These are some of the baseline demographic and clinical characteristics of the patients in this study, and you can see point out a few things. About 20% had upper tract disease, that is renal, pelvis, or ureter. About 40% of patients received neoadjuvant therapy, and you can see that a fair share of patients had node-positive disease at the time of resection. And so what did he show? He showed that the hazard ratios held up very, very nicely. Here, with the extended follow-up, the ITT population with a hazard ratio of 0.71. In the PD-L1 greater than or equal to 1%, it was 0.52. And I think this is really notable here. The Nivo median DFS, 52.6 months, as compared to 8.4. It's pretty striking. If you look at the forest plot, you could see that almost all of the subgroups favor the adjuvant nivolumab. Here's an exception with upper tract tumors, and this, I think you can't take too much into these subgroup analyses, but there is potentially some biology to explain this based on molecular subtypes and perhaps less response to immunotherapy and upper tract disease. But again, I wouldn't draw too much conclusion from subgroups. Additional endpoints, non-urothelial tract recurrence-free survival, again, significant for both the ITT and the PD-L1, 0.72 and 0.53. Similarly for distant metastases-free survival. And then they looked at an exploratory endpoint of second progression-free survival in this presentation. And this is time from randomization to disease progression after subsequent next line anti-cancer therapy or start of subsequent next line anti-cancer therapy or death. And here you can see that there is, again, an improvement both in the ITT population and the PD-L1 greater than or equal to 1% with a hazard ratio of 0.54 here. And so extended follow-up of a study that led to the FDA approval of adjuvant nivolumab, again, sort of establishing that these hazard ratios for DFS, both in the ITT and the PD-L1 positive population, very stable. And I think that, if you look at the actual median DFS, particularly the PD-L1 greater than or equal to 1% population, again, 52.6 months, more than 6 times the median DFS in the placebo arm. That exploratory PFS two endpoint is interesting. And I think really this just continues to establish this as a potential treatment option for patients with high-risk muscle-invasive bladder cancer.
So I have a question about theoretically who would benefit from this strategy. I believe the FDA indication just says it's for patients at high risk without specifying it. But what I hear, and you can correct me if I'm wrong on that, but what I hear from investigators is they use the entry criteria for the trial. So like you said, PT2 after neoadjuvant, T3 before. First of all, is that your approach? Am I right about the FDA incidentally?
Yeah, you're correct. I think you're right in the interpretation. I think that the historically, as I'm sure you're aware, what has been used in the adjuvant studies of chemotherapy has typically been that T3 and or node positive disease. So it's pretty consistent. We know patients, for example, with node positive disease post neoadjuvant chemotherapy. If you look at 5-year overall survival outcomes, they're close to zero. So there are certainly higher risk patients, in this group. And so I do think it's a conversation with patients, particularly since the Vigor 10 study was a negative study of adjuvant atezolizumab, and we don't have the pembrolizumab ambassador study yet. And, Dr. Pals has done some really exciting work with circulating tumor DNA, and there's a trial called the Invigor 11 study, which is, going to try to answer that question of looking at circulating tumor DNA to sort of select patients for adjuvant immunotherapy.
So my question is, theoretically, would you expect patients who are at lower risk to also benefit from adjuvant Nevo? And do you think that in some of those situations, do you use the trial criteria to decide whether or not they're going to be treated?
I do use the trial criteria to decide whether or not they're going to be treated. Um,
So if you
but
have
yeah,
patients who are at lower risk, do you think there's some of them who actually, if you apply, I mean, whether or not you think it's legitimate to apply the hazard rate going down the way they do like in breast cancer, for example, but do you think that patients who are lower than that bar would end up with a positive risk benefit ratio from, putting aside the issue of the negative trials, just looking at this study?
yeah. So I think there are going to be some patients for sure who are lower risk who may benefit from the use of adjuvant therapy. I think the issue is that you then get into the risk benefit of giving someone immune checkpoint inhibition for a year with the potential toxicity. These are long conversations to have, as you're aware, when you're talking about adjuvant therapy with patients. And this one's particularly difficult just based on the data we have. If you look at the circulating free DNA story, it looks as though you may be able to pull out those lower risk patients and not, subject them to a therapy that they don't need with the associated toxicity. So I'm really hoping that, we have that biomarker in the future to be able to do better in terms of selecting patients. I don't think you rely on subgroups at this point. I think you have to be really careful in doing that. So I have this conversation with my patients with high risk disease, but we talk about, the adjuvant chemotherapy data, the other studies, and the potential toxicity associated with treatment and the possibility of overtreatment.
All right, please continue.
So moving on to metastatic disease, there was some exciting work, updates of the Invigor 130 study. There were two studies that were exciting to a lot of people in bladder cancer in the metastatic space, where we were looking, much like has been done in lung cancer and other cancers, at the combination of chemotherapy and immunotherapy. And one was the Keynote 361 study with pembrolizumab, and this is the Invigor 130 study with atezolizumab. And so here, three arms: atezo and platinum-based chemotherapy, a atezolizumab monotherapy arm, and then a chemotherapy placebo arm. And you can see the hierarchical statistical design of this study, looking first at the progression-free survival, looking at arm A compared with arm C, and then from there, looking at overall survival in A versus C, B versus C, and B versus C in the high PD-L1 population. And so, again, this is looking specifically at this atezo monotherapy group. In the original analysis, there was a significant progression-free survival benefit associated with atezolizumab and chemotherapy as compared to the placebo chemotherapy. Although the median progression-free survival was at 8.3 versus 6.2 months. So, I think there was a lot of question about how clinically significant that really was, clinically meaningful, and really now without a survival benefit associated there and a negative data from the Keynote 361 trial with pembrolizumab. So that sort of drained a lot of the enthusiasm, along with the Javelin 100 bladder study that really established maintenance immunotherapy after chemotherapy. But this was really interesting to see. Here you can see the final overall survival analysis in the ITT population. In fact, no benefit with regard to overall survival of atezolizumab versus chemotherapy. But here it is in the PD-L1 high population. So this is the IC23 population, and you can see here hazard ratio is 0.56, whereas there's no benefit in these patients with low PD-L1. And if you remember back to about 2018, this is sort of resembles the revision of the FDA approval of both atezolizumab and pembrolizumab in bladder cancer, where they looked at some preliminary data and the indication was changed to look to only cisplatin ineligible patients who had high PD-L1 expression. Subsequently, atezolizumab was withdrawn, and subsequently, pembrolizumab changed the indication to patients who were unfit for any platinum-based chemotherapy. But I think this does lend, support for the potential benefit that can be seen with upfront immune checkpoint blockade in patients who are high PD-L1 who are not cisplatin eligible. And so, again, I agree with the author's conclusions that, no survival benefit, but the exploratory analysis is, I think, interesting and consistent with, I think what we've seen in the clinic when we care for some of these patients, and represents a consideration for first-line treatment for cisplatin ineligible patients, although again, we have level one evidence now with the Javel and Bladder 100, and so I think that that maintenance immunotherapy in patients who are chemotherapy candidates continues to remain the standard of care at present. Moving on to some, again, really provocative data with enfortumab vedotin in combination with pembrolizumab. So enfortumab vedotin is an antibody-drug conjugate. This is targeting Nectin-4 using the payload monomethyl auristatin E. And here is data from the EV-103 cohort A. So this was published by Chris Holmes in the Journal of Clinical Oncology. This was an expansion cohort looking at EV given on days 1 and 8 with pembrolizumab. And here you can see the response rate was 73% with a CR rate of 15.6%. You could see the durability of some of these responses that we're seeing. And if you looked at the Kaplan-Meier curves, again, these median duration of response, over 25 months, and here's the progression-free survival at 12 months and the median overall survival of 26 months. And so, I think that in this dose escalation expansion cohort within A, this really set the stage for, more study of this combination of immunotherapy and EV. Treatment-related side effects were consistent with the individual agents, a little bit more in the way of skin toxicity and combining pembro and enfortumab vedotin, but, the neuropathy, fatigue, alopecia, skin side effects. And these are things, again, that we're quite familiar and comfortable with managing in these patients. This was part of a multi-cohort study, the EV-103 study, which is, again, a multi-cohort study that's looking at patients in different clinical disease states with combination approaches, including immunotherapy and chemotherapy. I showed you the cohort A data. This is the cohort K data. And so, again, that's that dose escalation expansion cohort A that we just saw. Cohort K looked to establish the activity of EVP further in patients who were in the first-line cisplatin ineligible setting. There was also an EV monotherapy group here, and patients were randomized. It's important to note that there's no formal statistical comparison between these two treatment arms, but they needed to get some additional information related to EV monotherapy in this particular patient population, and this represented a really nice opportunity to be able to do that, the primary endpoint being overall response and a bunch of important secondary endpoints, as well as exploratory endpoints, which I'll come to in terms of patient-reported outcomes. And so this was the data that Dr. Rosenberg presented at ESMO in 2022. Response rate 64.5% for EV plus P. Median time to response of 2 months. 97% of patients had tumor reduction, and 86% of the responses were observed at the first assessment. So I think this is, really not we haven't seen this before, in patients in the first line cisplatin ineligible space. If you looked at the EV monotherapy arm, response rate of 45.2%, and this is very consistent with the prior results that we've seen with EV monotherapy in a second line plus setting in patients with locally advanced or metastatic disease. Median duration of response for EV plus P was not reached. 65% of responders were still responding at 12 months. And here are the PFS and OS curves, which I think are, again, really promising. Median PFS not reached here in the EVP arm. And if you look at median overall survival, about 22 months. And so really establishing after the cohort A data that there is this exciting activity associated. And there is a randomized trial that's going on called EV302, which is looking at this in that clinical disease state as compared to chemotherapy in patients who are both ineligible and eligible for cisplatin-based chemotherapy, trying to get a handle on whether or not this could actually become a new standard of care in patients with bladder cancer, metastatic in the first line setting. Um, Dr. O'Donnell looked at the subgroup analysis of response rate as a poster presentation at the GU Cancer Symposium. And you can see here, again, the numbers are small. I mean, these are underpowered. You can't draw definitive conclusions here. But I think what you can say, just if you sort of look here, that the overall responses are very consistent, across these different subgroups of patients, both for EV plus pembrolizumab, where the response rates are higher, as well as among the EV monotherapy patients. And these are quite consistent with what we've seen previously. And so, again, just establishing that there appears to be benefit across subgroups. EVPs being further evaluated again in the EV302 study. And it's also being looked at, in patients in the MIBC setting. And, we really look forward to, more data to understand how this potentially could become a new standard of care. So I presented some work looking at patient-reported outcomes for the EVK uh, group of patients. Here we looked at patient-reported outcomes using the EORTC QLQC30 and the brief pain inventory short form. These were administered at baseline, weekly for cycles 1 through 3, and then every cycle until the end of treatment. And you can see the ARTC-QLQC30 is grouped into cancer-related symptoms, function, and quality of life, and the BPISF looks at pain with different ranges. Here, higher scores representing greater symptom burden, higher functioning, and higher quality of life, and here, higher scores representing more pain. And here is the data from the symptom scales, and EVP was associated with preservation or improvement in symptom scale scores. And I think most notably here, you see this meaningful improvement in pain at week 24. You do see some transient worsening of symptoms, most notably diarrhea, that then returns to baseline. And it's important to note here that the tool that we use doesn't actually capture the cause of pain. So, we know that EV causes neuropathy, but it wasn't possible to determine specifically neuropathic pain, based on the use of this tool, but it's certainly promising to see the improvement. If you look, again, using the BPISF, this is looking at pain. More than 1/3 of patients had moderate to severe pain at baseline. And then if you look at the improvement in worse pain, you can see that this was demonstrated quite nicely with the EVP treatment arm. Here you can see this meaningful improvement by week 24. And worse pain, average pain, and pain interference and severity all showed improvement from week 4 through week 24. And if you look here in the 45% of patients who had moderate to severe pain at baseline, 85.7% had a sustained improvement in pain with a median time to improvement of 1.1 months. And I do think this mirrors what certainly I've experienced in speaking with other investigators in the clinic, where EV does help in this way with these patients who are experiencing pain with rapid responses when those patients are in fact responding to treatment. And so, I think this just lends additional support to the exciting efficacy data that we're seeing in EV 103 cohort K and A with regard to patient-reported outcomes. So moving on to, again, metastatic disease, but these are in patients who are previously treated with platinum-based chemotherapy and immune checkpoint blockade. This was the EV301 study. Dr. Rosenberg presented the 24-month findings from this study. And here, enfortumab was the randomization versus chemotherapy with either docetaxel, paclitaxel, or vinflunine, with a primary endpoint of overall survival. And this led to the full approval of enfortumab vedotin. And this was the 24-month follow-up data. And I think what you can see, this was the NEJAM publication with a median follow-up of 11.1 months. Here are the medians. Here are the hazard ratio, zero point 0.7, 0.62 for PFS. And again, data holds up beautifully. If you look at the median follow-up of about 24 months, almost identical with regard to these hazard ratios. Again, I think just establishing this as a standard of care in patients who progress after upfront platinum-based chemotherapy and immune checkpoint blockade.
We actually had a case that a medical oncologist presented a couple weeks ago of a patient with a lot of comorbidities, thought to be platinum ineligible. And the doc actually was able to get EV plus Pembro and treated him. And one of the questions he had, and I'm curious in general, how EV and EV Pembro is tolerated in patients with a lot of comorbidities and very elderly. Do you have to do dose reduction? What do we know about tolerability of the combination, just EV in general, in older, frail patients?
Yeah, I mean, I think like anything, we take the data from the clinical trials and those selected populations of patients who are ECOG 0, 1, and then we go into our clinics, right? And we take care of patients who are not those patients on clinical trials. And so I think that much like any other anti-cancer therapy that has toxicity, we use the patient in front of us and look at their coexisting medical problems and make decisions. And so what I would say is, most importantly, to examine those specific toxicities that are related to that agent, and in particular, the hyperglycemia, the neurotoxicity, and the skin toxicity. I think in older patients, all of these treatments can be more difficult. I think dose modification, we absolutely do. You got to be on top of it. And so we either do dose modification, and I think sometimes we also do schedule modification as well, which is actually not really embedded in the current studies. And so we may have to omit a dose and do a 1/8 schedule as an example in patients just getting EV and omit day 15. We've even done other iterations as well based on patient tolerability. I don't know if that answers your question.
Yeah, no, it does. And also, I'm kind of hearing, is this before the FDA right now in platinum ineligible patients?
It is. Yeah, so we're waiting to understand what this is going to look like for our patients. Don't have timelines, but whether or not this will receive an accelerated approval based on the data from cohort K is, I think, to be determined.
Please continue.
Sure. And so moving on to targeted agents, this was our first targeted agent. We talked about erdafitinib in the non-muscle invasive disease space. Again, it's an oral pan-FGFR1/4 inhibitor. This was data from the BLC 2001 study that was initially presented and published by Dr. Steve Garatke. Patients with metastatic UC had FGFR mutations or fusions. Prevalence in metastatic and muscle invasive disease is somewhere in the 15 to 20% range, significantly higher in patients with NMIBC. And so here, the response rate to erdafitinib, 40%. This was the original data with a median overall survival of about 14 months. This is the updated data, the long-term follow-up. Here, PFS, 5.5 months, and the median overall survival was 11.3 months. Activity in patients who recurred after chemotherapy, as well as after prior immunotherapy as well. And so clearly an active agent. It has its toxicities, as we talked about earlier. I always say to patients, just because it's an oral agent and we're not giving it to you intravenously, this is still something that in many ways we need to even monitor more closely. Some of the toxicities we're less familiar with as medical oncologists, like central serous retinopathy and retinal pigment epithelial detachment. And these patients need to be seen by ophthalmologists along the way for regular interval screenings. And the nail toxicities can be quite significant for these patients that often require dose holds and modification. And so again, I think like anything, if you know the toxicities of the drug and know how to follow these patients and know how to involve the other subspecialists, you'll be in good shape. But you definitely need to stay on top of it. Moving on to another antibody drug conjugate, this is the Trophy U01 study of sacituzumab govitecan in platinum-ineligible patients with metastatic urothelial cancer progressing after prior checkpoint inhibition. So sacituzumab govitecan is an anti-Trop2 agent using a hydrolyzable linker to SN38, which is the active payload, which is the active metabolite of irinotecan, a topoisomerase 1 inhibitor. And so the original data that we saw was from cohort A, which led to the accelerated approval. This is also approved in breast cancer, as you're aware. And here, this was data that Dr. Petrolak presented at the GU Cancer Symposium, looking in patients who progressed after immune checkpoint inhibition but were platinum ineligible at the start of the study. Primary endpoint was overall response. What do these patients look like? About 30% of patients had evidence of liver metastases, 50% received prior neoadjuvant chemotherapy, 18% received prior enfortumab vedotin, and these were the immune checkpoint inhibitors that patients received. And so, in looking here, response rate a little bit higher than what we saw in the patients that previously received chemotherapy. Here it was 32%. There weren't any complete responses, but there was an overall response about 54% in patients without prior platinum-based chemotherapy or enfortumab vedotin. That is, they could have received platinum-based chemotherapy in the neoadjuvant setting here, but not for metastatic disease. Median duration of response 5.6 months, and you can see that some of these responses are durable. It's not a lot of patients here, but I think again just confirming that that this agent certainly has activity, and this is the progression-free survival and overall survival curve. So a median PFS of 5.6 months and a median overall survival of 13.5 months. In the follow-up here, the median's approximately 9 months. So, what do I take from this? I take that sacituzumab govitecan has activity in patients with metastatic urothelial cancer. That being said, it also has toxicity, and here, this is a different type of toxicity based on the payload. So this is what we know comes with SN38. It's the myelosuppression, it's the diarrhea, it's the nausea, and I think what's notable here is that GCSF was received by 18% of patients for primary prophylaxis and 26% for secondary. So over 40% of patients needed to receive growth factor support with this agent. And so that's, I think one of the most important take homes with this particular agent. That when you asked me about older patients who are frail, and I think we really need to think about, for example, the use of this agent with regard to the myelosuppression and the potential use of upfront growth factor support. This is the study that has not reported out yet, similar to the EV301 study. This is looking at patients with metastatic disease, the large randomized phase 3 study in patients progressing after platinum-based chemotherapy and immune checkpoint inhibition, randomized to sacituzumab govitecan versus physician choice chemotherapy with a primary endpoint of overall survival. So we'll see where this ultimately lands up after the trophy study.
I know that typically enfortumab is given before sacituzumab. I know the data are stronger. I'm just kind of curious, though, in terms of relative tolerability, not just from published literature, but from your own experience, from a quality of life point of view, how would you compare sacituzumab to EV?
Yeah, so it's a great question, and I think we're absent a little bit data. There was some preliminary data related to the response rates in patients who previously received enfortumab vedotin, and what that looks like maybe in the, as high as 30% range. I think that my experience is that sacituzumab is perhaps a little bit more difficult to tolerate, but again, it's a little bit unfair because I've used it in patients that have been previously treated with enfortumab vedotin. But I do think that the spectrum of side effects associated with it, particularly with the GI and myelosuppression, may be more difficult in some of those, older patients that you described earlier. There may be select patients for which enfortumab is just not appropriate, with significant neuropathy or or very poorly controlled diabetes and things like that. But I think in general, the way that we do this now is certainly with enfortumab first. And again, the strength of the evidence is more there, as you suggested.
And is sacituzumab plus IO being looked at?
Yeah, and I'm going to get to that. I've got some slides. It has actually been looked at, and there's some interesting data with regard to comparing, although not directly, the different combinations of immunotherapy and immune check and antibody drug conjugates.
Okay, please
So
continue.
yeah, absolutely. So, so what about other targeted therapies? I feel like we went from real excitement with the Cancer Genome Atlas in bladder cancer, where we disclosed all of these potential targetable alterations in urothelial cancer, to then kind of dropping that quickly because then came immune checkpoint blockade. And, we went a bunch of years with the approvals of immune checkpoint inhibitors, and I kind of think we're back to where we started. And this is the Bayou study of durvalumab, an anti-PD-L1 agent plus olaparib, a PARP inhibitor in previously untreated platinum-ineligible patients with metastatic disease. And so, GU Cancer Symposium, as I suspect you're aware, was really interesting this year, particularly in prostate cancer, with all the data with PARP inhibition. Well, I think there's a potential role in urothelial cancer as well. Homologous recombination repair gene mutations are actually quite common in urothelial cancer. If you look at germline alterations, germline alterations in urothelial cancer, on the order of somewhere about 14% in the Memorial experience. And, if you look at what those are, those DDRs, they're, maybe on the order of 6+% of patients, in terms of the BRCA1/2 and the mismatch repair defects. And so they're there. And if you look at somatic alterations, it's probably upwards of about 25% of patients will have some DDR alteration. This is a randomized multi-center double-blind phase 2 trial looking at durva with placebo versus durva and olaparib with a primary endpoint of progression-free survival. And you can see here they looked also at survival outcomes in the HR mutated group. And so here's the data, negative in the ITT population, but this is the HR mutated group. And here what you can see is this suggestion that, in fact, if you select out patients who have homologous recombination repair alterations, that you can select for potential sensitivity to PARP inhibition here in combination with durvalumab. So I think there's more to come here. There's been some other data in the maintenance setting which suggests similar. And so I'm excited again to think about the use of targeted agents in urothelial cancer and potential new combinations even with immunotherapy here. So other antibody drug conjugates, new agents, this is RC48 ADC. So this is a HER2 targeting agent, another ADC. This is includes the payload monomethyl auristatin E, which we've already heard about with enfortumab vedotin. There were 3 abstracts actually at the ASCO annual meeting. And the first abstract looked at patients who are HER2 high. I think getting to one of the questions, or part of the questions that you were starting to ask earlier, one of the things here is, are there real differences between some of these anti-drug conjugates based on the payload and even potentially based on the linker that might pair better with different therapies? Here's just looking at HER2-directed therapies. So this is TDM1, deruxtecan, and this is disitamab, which is the RC48. And here you can see, antimicrotubule, topoisomerase 1, MMAE, and maybe there are better effects, when you pair these with, for example, immunotherapy. And so this was a nice slide by Dr. Galsky just pointing out, the antigen antibody payload and linker issues when it comes to these drugs. This is looking at HER2 2/3 plus metastatic UC response rate 50.5%. When you looked at the high IHC2 plus, FISH plus, or IHC3, 62.2%, a little bit lower in IHC2 plus, FISH negative. And here, I think, very exciting activity in patients with visceral metastatic disease at 52% and metastatic disease to the liver similarly. As well as patients that received, prior immune checkpoint inhibition and chemotherapy. There also does appear to be activity in HER2 low. It's not nearly as pronounced, but here in the IHC1 plus group, you can see that there is in fact responses that are seen. And I think this is something that's sort of panned out in breast cancer as well, where you can see responses in patients who have lower levels of HER2 expression. And then this has also been looked at in a third abstract in combination with the anti-PD-1 agent toripalimab. And this is very striking, right? Very similar to what we saw with the combination of EV and pembrolizumab, with a close to 72% response rate, again, with durability to many of these responses. And so getting back to your excellent question, which is, is there, something about these combinations? Are there differences, for example, in sacituzumab and immunotherapy as compared to enfortumab or disitamab? And so here's another nice table that looks at the response rates with these different combinations with immunotherapy. And I think what's quite striking here is that there's very similar response rates here. The payload is the MMAE, which is this antitubulin agent, which is quite different than what was seen with trastuzumab deruxtecan and nivolumab, or sacituzumab govitecan and pembrolizumab. And so, I think that this is early. Clearly not direct comparisons, but maybe a suggestion that choosing the right payload to go along with immunotherapy may make a difference with regard to the sort of effect that we see.